want your old, crusty, dried up cells. You want new baby cells. And I'm like, oh my goodness, really? What this is really happening. And people are on their edge of their seats. They're in a desperate situation. They're looking for anything to make their need better.
We realized this, they were telling us when they came to the office with the marketing material, those cell numbers were done on the freshly harvested product. More and more people kind of got on board with, hey, these products have some growth factor in them, but they aren't really stem cell products. For those of you that are out there that don't understand that, are there guys in black showing up at your office and put you in cuffs and taking you to the jail? Now, usually it's just a warning saying, hey, what you're doing, these are the things we don't agree with. These are the things you need to clean up.
Welcome. We are so happy to have you here. This is Conversations in Regenerative Medicine, where we are exploring the frontiers of PRP, BMC, MFAT, and maybe some other things. Today is very exciting. And so, this is a little bit of a different experience. We are absolutely loving this. And this is more of a conversation rather than a lecture. And this may be giving you some insights that may shape your interventional orthobiologics and tackle some of the controversial pieces of the puzzle. So, for those of you who don't know me, I'm Dr. Ariana DeMers. I am a board-certified fellowship-trained orthopedic sports medicine surgeon and regenerative medicine aficionado. I do a lot of training and educating in orthobiologics and ultrasound, and I have successfully moved my practice away from commercial insurance, and I am most passionate about helping doctors to incorporate orthobiologics in cash-based practice seamlessly. So I am so happy to introduce to you all. She needs no introduction, but joining us tonight is Kristin Oliver. She is a board-certified family medicine, a physician, fellowship trained in sports medicine, has her master's in public health, is the co-founder of Blue Tail Medical Group. Greater than 15 years ago, pioneer in the field, leader in regenerative orthopedics, over 25,000 orthobiologic patients treated. So, man, I'm trying to keep speed with you. Expertise in PRP, bone marrow concentrate, lipoaspirate, and of course, advanced musculoskeletal ultrasound. So, holy cow, I'm so glad to have you here. I'm really looking forward to our conversation. It's going to be so much fun. For everybody that's here today, thanks for joining me. This is always so much fun. I really love having a fireside chat, pulling back the curtain and getting to know us, exploring controversial topics in orthobiologics, regenerative medicine, and hopefully gaining some actionable insights that you can implement in your own practice immediately. At the end, we will have a live Q&A session to get all of your burning questions answered. So, I do believe that orthobiologic treatments will be first-line treatment for musculoskeletal care in the next 5 years. We are hitting an inflection point where the train is leaving the station. And if you are not actively offering these treatments to your patients, you gotta get on the train. It is leaving. So the thing about the cash-based practice and integration of orthobiologics in your existing practice is this is hard. And having a successful orthobiologics practice sometimes uncovers these anxieties about the fact that maybe, I don't know all of the things. Maybe I've tried some things and they either did or did not work. Maybe we don't know all of the science or the latest science, techniques, cash-based business, marketing, sales. And maybe you've just thought, I'm just not good at this business thing. But honestly, it's not our fault. We just didn't learn this in school. It is a learnable skill. We just didn't learn this one. So don't stress out. This is absolutely doable. And I'm sure some of you are really wondering, how do I create a successful orthobiologic practice so we can capitalize on this $4 billion orthobiologics market out there? We do deserve to win. So why are we struggling, right? So if you're struggling with anything, because we're going to go over this, tell me the most difficult thing that you're struggling with right now, and we'll maybe address that as we go forward. So the question is how to win, right? We are going to be talking about science today, but we also need to consider how we talk about this with our patients. So we all win. The doctors win, the patients win, our practice wins. And so how do we do that? Well, we need a system. And we're not going to go over this entire system today, but we are going to get a little further down the journey to be wildly successful in your orthobiologic practice. So let's get down to really starting a little bit more on this orthobiologic knowledge. All right, so we have questions for Kristin. This is what we're here for. We're going to ask her some really interesting, fun things. This is a subject that is near and dear to her heart, and she is passionate about really, knocking the dust off this stuff and getting down to business. So the first question I have is, are most stem cell claims in placenta and cord blood products scientifically false, or are they just strategically vague enough to avoid the accountability that our government has placed?
That's actually a great question. If I can, I'd love to break that into kind of two facets. I think there's the manufacturing facet, like the manufacturer issue, and then there's the clinical issue. So, I can tell you back in 2018, 19-ish, when this stuff first came to market, we would have reps come from the companies into the office, and they would show us these amazing numbers of stem cells that were in this little bottle of product. And, we started to use it. One of my partners actually started to use it to begin with. He was sort of like hey, let's let Mikey try it. But we kept good data on it. And really, he wasn't getting improvement for more than about 6 months, if that. Intra-articularly, it was primarily intra-articularly for osteoarthritis. And we had a relationship with Franciscan University and sent samples to them. And the main PhD there ran through those. And, after culturing, there were no living cells. So we realized what they were telling us when they came to the office with the marketing material, those cell numbers were done on the freshly harvested product, not after it had been, lyophilized, frozen, irradiated, etc. And then kind of shortly after that, Lisa Fortier did a study on amnion, same thing. You had IOF doing it. Albero Pinheiro actually had a great paper on it. So more and more people kind of got on board with, hey, these products have some growth factor in them, but they aren't really stem cell products. Okay, so what's happened in the last year or two is that a few of the manufacturing companies like Lux and NVIDIA, not NVIDIA, NVIDIA, and I think BioXTech is another one. They received formal FDA warning letters. And for those of you that are out there that don't understand that, what does that mean? Are there guys in black showing up at your office and put you in cuffs and taking you to the jail? No, usually it's just a warning saying, hey, what you're doing, these are the things we don't agree with. These are the things you need to clean up. So if you go out there and you look at most of the websites now, like MiMedx, Vivex, those sites are really clean. The websites are extremely clean. Their written marketing material is very clean. They don't talk about stem cells. They don't talk about applications orthopedically except for wound care. So they're staying within that homologous, minimally manipulated thing they're supposed to. But I don't know, do they still stay within that framework in the office? I don't know if you've had any exposure to them. Might be interesting to see.
Yeah, so I think that's so interesting. So I appreciate the way that you break that down, okay, is the company, making false claims or just being super vague so they don't get a slap on the wrist? The answer is clearly Yes, right?
Mm-hmm.
Now, I have some doctors who are like, this is the hill they're going to die on. They're like,
Mm-hmm.
my patients do so good. You're like, it's not fair. And then there are, so the question is, number one, is there stem cells in it? Pretty across the board, it seems like not exactly. Is there growth factors in it?
Yes.
Yes. Now, so what I talk to my patients about, I'm like, because they're like, oh, I want that cord blood stuff. I want the Wharton's jelly. I'm like, well, okay, let's back up. Clearly, there has been a struggle to demonstrate that there is viable cells. Okay, so there's growth factors. Cool. When would this be the best idea? Okay, well, what if my human doesn't have good growth factors? Maybe they've had irradiation, maybe they are not metabolically well. Then we start to think, okay, this might be viable. Now, the second part is it legal? I don't think
Good question.
Yeah, right.
Yeah, so I would say that the biggest issue has become kind of this gray zone, right? And there's light gray and there's dark gray, right? There's this big, huge gray zone, especially in states now like Florida, Utah, which was one of the first adopters of placental cells, which is where I live, and why it's sort of near and dear to my heart. And also places like Wyoming, which is very forward in the, some of my own cells are my own cells, right? Like I can do with them what I want to. So, but again, from the amnion perspective, I think there's value in those patients who are thrombocytopenic for some reason. They don't have signaling, they don't have growth factor. I think it's a viable product for those individuals, but it shouldn't be marketed as a stem cell product. Which brings me to the second part, which is the clinical part of this question. And, I like to believe the best in everyone, and that the wool is just getting pulled over the eyes of the practitioner, and that they believe what we did to start with. And that was, hey, there's all these stem cells in there because I'm getting this white paper and I don't realize it's on the pre-frozen product. But when you get right down to it, if you look at the number of businesses in states like Florida, Utah, Texas, that are, there's stem cells all over their websites, and they're using an umbilical product, a placental product. And we know that they may have a few cells, but most studies have showed no significant living cells.
Yeah.
Not to say, I don't mind if you market it as a growth factor product, right? Say to people, hey, if you don't want to get your blood drawn,
right.
You can go and I can shoot this little bottle in there.
Yeah. And is it legal? Probably not.
No.
Who's going to be in trouble? Probably both of you. If you try to have Medicare pay for it, you're definitely going to get clawback. So please don't do that. And so it is really interesting, right? And I think that the dichotomy of 351 pathway versus 361 pathway, 351 pathway for FDA approval is a drug. And so if you have not jumped through all the hoops, done all of the paperwork, done all of the studies, done all of the FDA trials, you're not gonna go down that 351 pathway. And so everybody is really wanting to push for the 361 pathway. And if you're in a 361 pathway, you have to prove that you're minimally manipulated, that it's homologous use. I just talked to a doctor yesterday. He was like, well, it's homologous use. It's umbilical cord for cushioning. I'm like, okay. So Connie Chu, Dr. Connie Chu, a couple years ago stood up and said, for half of the population, that may be true. If you've ever had umbilical cord within you and you've been pregnant or you've had a fetus within you, that may be considered homologous use. For those of you who have never been pregnant, that is very unlikely to be homologous use. So, how far do you want to stretch that, right? How far are you willing to stretch it, and at what point? If you are making, millions and millions of dollars, some companies, that is the price of doing business, to fight with the FDA and to close down, set up shop somewhere else and then rebrand, right? Yeah. So
yeah, totally. And a lot of the times, like when these first came out, what you really saw was a host. There were a few companies which have now been sanctioned. Actually, like closed by the FDA, that would market to chiropractors. And nothing against chiropractors. I mean, some of my best referral sources are chiropractors. And, they would market to them. They'd set this up in their shop. They'd provide them with marketing materials. They would they'd take them, they would have a nurse practitioner that the provider, the chiropractor sort of affiliated with. That nurse practitioner would go for a weekend course, learn how to do ultrasound, come back in. And then there was an individual who kind of was the salesperson in the office, sold it. They did the injection. And most of the time, in many of the states where the nurse practitioner or physician assistant couldn't work separately from could work separately and individually without oversight from a physician, they could just do it. In the ones where they needed a physician, they would just pay a physician per hour. Like in Colombia, we had this, and there was a guy who was just he'd done research for 25 years. Like he hadn't taken care of a patient since residency, and he was their overseer. So it's a little shady, right?
Yeah. Yeah, so there's some really good questions here. There's some questions here that are really interesting. Florida requires third-party live cell viability analysis, and he says, I believe Wyoming too. Thoughts? Yeah, awesome. Let's have that, live cell viability analysis through third-party testing. Great. Yes. And, GMP manufacturing facilities. Absolutely. Right. Now, is it FDA cleared or approved? Because a lot of these companies, I just had one in my office last week telling me that it was FDA approved. It's clearly not. And I'm in California, so that's a risky little biscuit.
Yeah. And the question becomes, those states, Florida, and I get that point. So I actually read through the entire law, and Florida does require that, but it requires it of the manufacturer. Okay, not of the provider. But the question becomes, I mean, if we believe the studies that have been done on these products previously by third parties that aren't, interested in the monetary aspect, the question becomes is all like, where are those studies by these companies that show viability after thawing, right? I don't see them out there. And if Florida requires them, is the manufacturer actually providing them to the physician? Now, I don't work in Florida. I don't know. In Utah, they're primarily used at this point for aesthetics. Yeah. Like the aesthetics market here is stupid. So if you want to make money here, be an esthetician or a dermatologist. So
and there's a lot of discussion and that there's differential licensure regarding topical injections versus intra-articular injections from a licensing perspective.
Correct. Yes. And they are FDA approved for certain applications. So they are FDA approved, a lot of these, for wound care, for wound healing, for use, orthopedic surgery as a wound application. And there's some others that are used as matrices in the orthopedic market. And interestingly enough, there's a company called Renew, RENU, and they're formally applying to the FDA here in early 2026 for a BLA, so a biologic licensing application. They kind of put in this rolling initial thing in 2025, and it's for osteoarthritis. So it'll be sort of interesting to see what data they show. Yeah. But again, like you said, there's growth factor.
Mm-hmm. Absolutely. So, everybody gets a little riled up, and I think people are on both sides of the fence, right? I'm having a very large conversation in the chat, which I'll share with you. Everyone can share.
Am I getting hate mail?
Nobody's going to get hate mail. And here's why is, honestly, we're just talking.
We're trying to figure it out.
Things that what I hope we take away from this is that the manufacturers are in this to make money, right? Mm-hmm. Who gets caught in the middle is physicians, right? And we're trying to keep our clinic afloat, do right by our patients, and follow as much guidance as we know how to follow. And when states and FDA is giving varying data, it's just hard to sometimes figure out what the right, and it does vary by state. So it is really fascinating to me how much excitement people have around this topic. And I think there's a lot of rhetoric that is, a little bit more inflammatory. That's not what we're doing here today. I think what we want to talk about is, there are bigger problems, right? Is like, okay, so the bigger problem that the product, the claims, or the business model that incentivizes overselling, right? Is it because it's a cash-based service and it's moderately unregulated? Some people would call it the wild wild west or wild wild southeast. I'm in Florida a lot, and they do have some interesting perspectives on these things and requirements, not only by the manufacturer, and then the question is the manufacturer doing what they say they're doing? And yeah. Is the incentive there for them to be on the up and up?
Yeah, I think if I look at that question, it's tough because it's all kind of intertwined. But I would say that the product is not a bad product. I'm nothing against the product. I think the product is a great product. I think it's great. It's just the question is, should it be marketed as a stem cell product? People have issues with us marketing bone marrow concentrate as a stem cell, right? They're like, oh, there's only just a teeny bit of stem cells in there. I get that. There only is. If you tell your patient that, great. But if you're going to your patient and you're saying, I'm giving you this, if you're having a seminar and you're telling your patients, hey, I'm choosing this placental product and promoting it. Let's say, we're going to say birth tissue product. And I'm doing it because these cells are young and your cells are old. And your cells are worthless. Why wouldn't you want a nice young cell versus an old cell? And to me, that is the business model issue, right? But the business model kind of relies on the claim. Although I believe the product is a good product, it is primarily, unless it's proven so before provided to the practitioner, it's primarily a growth factor product, sort of like PRP.
Yeah, absolutely. So, and then you mix money into it, and everyone starts to have a coronary about money. Like, I think as a whole, the general public has an issue with physicians making money. They think we're all rich. If they looked at my Medicare reimbursement, they'd fall over dead, right?
They could only read their own EOBs.
Even other physicians, I'm quite vocal on what I get paid to do a knee replacement. $1,100 for the surgery, for the pre-op, and the 90-day global is not very much.
No.
It's same. Quite shocking. One of my anesthesiologist friends was like, didn't you miss a zero? I was like, gosh, I really wish so, but no. It's not $11,000, it's $1,100. And so anytime that question of money, I think it starts to get a little bit more dicey. So clearly we still have questions. So when patients come in asking for that, I want those baby cells, I want those placental stem cell shots, is it ethical to offer PRP as an alternative? Or should we be having a more nuanced conversation about what actually is a stem cell? Is it a MSC? Is it a mesenchymal stem cell? Is it a medicinal signaling cell? Is it autologous? Is it allogeneic? How is it processed? How do we know? That's a big conversation. And what we don't want is the bait and switch. And is saying, oh, well, yeah, I want that stem cell thing. And you're like, okay, here you go. Here's some PRP. Is that a little risky, or is that onus on us to try to crystallize the differences and the nuances in the landscape of orthobiologics, both autologous and allogeneic?
Yeah, that's good. I don't think it's a bait and switch, because I think of a bait and switch like someone comes in wanting like a Mazda, right? And you get them to buy a Maserati. To me, that's sort of a bait and switch. Yeah, exactly. To them, correct. But I feel like, to me, it's ethical to explain it to them. The problem is, how do you approach it without throwing a colleague under the bus, right? I'm like, if you can't say something good, just don't say anything at all. And so how do you do that? and be respectful. Because if you all of a sudden, me personally, when I would deal with this exact question in my office, multiple times, I would say they would ask me, and, I would have to very delicately talk to them about placental cells. I'd explain I can give you significant literature if they can come back with literature that shows you what is injected after it thaws. And I explained the freeze thaw, gave them some websites. And, there were a few patients that despite the conversation, because, you don't want to spend an hour and a half in there getting on your soapbox, right? Because they aren't going to appreciate that. And you're not going to appreciate that. And your staff isn't going to appreciate that. But you want to be able to say, ethically, I have to tell you that, those are great products, but they contain growth factor, which we can also get from your own platelets. Okay. And probably is the same cost and with less risk because it's homologous. Even less cost depending upon what device you're using. So, to me, it's sort of that ethically, I think I need to tell them. I don't feel bad telling them, but I want to do it in a kind of a delicate way.
Absolutely. Absolutely. I think that I've been to one of those conferences you're telling me about.
Oh, really? Crazy.
Oh my goodness. I snuck in the back door and I was sitting there and he's like, you don't want your old, crusty, dried up cells. You want new baby cells. And I'm like, oh my goodness, really? What this is really happening. And people are on their edge of their seats. They're in a desperate situation. They're looking for anything to make their knee better. And I'm just thinking, oh my goodness, this is what is happening. It was someone coming to my town, didn't live in my town, was recruiting to a different town. And it's like, oh my goodness. And then unfortunately I get the down the line effect where they've come in, they've spent, their life savings on this and they're no better off.
They're no better. I know, it's very sad. So you're just trying to, and then it gives honestly a bad name to orthobiologics in general. People sit around and they talk at like the canasta table or the bridge table or the hair salon. And, they'll say, oh, don't do that. My friend, Joyce had that done and it didn't work. And it turns out, so there's sort of this like, I don't know. It's sort of, the orthobiologics in general, when you consider all the factors that we have to put into success, from the system to the practitioner to checking cell count. I mean, all those things are so variable. And then you add this other thing in, and it just seems like it muddies the water more. And then, when you have different states with different laws, then, okay, I'm a practitioner. I work in Texas, Utah, and I'm being told it's okay as long as I post a sign that's like in Utah, you have to post a sign that's, I think it's 8.5 by 11, no smaller. And the font that says this is a non-FDA, approved procedure or device, or, I should say application, that has to be in print that is no smaller than like a 40 font. I mean, there's some interesting rules, but every state's a little different. And then the question really becomes, does the state overrule the federal government? Which is no, in most cases, right? Although I may be wrong. Maybe the state does rule.
Yeah. I mean, man, this is such an interesting time to be, talking about FDA, talking about state versus federal. Like, this is all very fluid right now. So what is true today may not be true tomorrow. So I think the onus is on us to have as much information as we can gather and, seek good counsel. I think the counsel, I have a license in Florida and I have a license in California. And so those states are not the same. Those restrictions are not the same at all. And so when I seek counsel from qualified persons, it's all about protection of my patient, adequate discussion. And I'm going to put this out there. And I think we're all a little remiss in this off-label discussion. So when you dig into using things off-label, we have to, the onus and the responsibility to be able to use something off-label is very important for us to go over why it is that we think this seems like a reasonable option to use off-label, what the clear risks and benefits of this off-label use would be for this patient, and what is the relevant literature that would support this off-label use. I can tell you, I have not had adequate conversations about off-label use for medications that we use off-label use all the time, right? So we use gabapentin off-label for pain all the time. I will tell you, I have not had that conversation clearly when I prescribe gabapentin, right? I say it is a nerve medication, it was designed for seizures, and we use it for pain. I don't produce them with the research studies that support this conversation about off-label use. I think the onus is on me, and I probably should, right? As we delve into treatments that have an indication and we're doing it off-label, like PRP, with a 510K cleared device, the onus is on us to absolutely offer that ethical and scientific realm of how we came to this conclusion that we should be considering this off-label application for our patient use.
Yeah, and I think also not only discussing it, and when you say off-label, the patients don't quite get it. So actually gabapentin is what I used as an example. I would say, so this is off-label. PRP can be used for the same reason if I'm in the operating room, right? Because otherwise, or BMC or MFAT, so the 510K says orthopedic surgery. And so if it's an office-based procedure, you are strictly using it off-label, but that doesn't mean so I say there's this medicine, we call it, gabapentin or Neurontin, and it's used for seizures, but we found out it helped for pain. So now we can use it for pain. And I explained the cost of getting a 510K for one application so that drug companies often get it for one, and then are able to apply it off-label. And it's on the onus of the physician. It's our decision to say this is safe and potentially effective.
Yeah, it is. The responsibility lies on us to help safeguard our patients. So yeah, absolutely. This is so, I love to talk about this. It's so, clearly we have more questions.
Well, and I really think there's a lot of gray. Like I said before, I think the hardest part of this, when you add in all the states now having their own, there's like this gray that's gone from light gray to dark gray. And so, you're sort of like my accountant always says, it's okay to sit on the fence and it's okay to kind of lean on the fence, but you don't want to jump over the fence, right? So where is that line?
Yeah, absolutely. The question that I have is what is the hardest truth doctors need to hear about why patients buy these offers, even when the evidence is thin or very, very scant, right? Why? And we were talking about the marketing, this age bias, younger cells must be better. So how do we support our patients, but also help our patients understand that this may or may not be, there may not be very much data, but the data we do have points to that maybe it's helpful or maybe it's not helpful, right? So
yeah, I think
help our patients.
Yeah, I think the hardest part is the human nature in the fact that, we all want a magic pill. We all want an easy route. I mean,
Yes.
We all want to hear, oh gosh, the idea I go to a seminar or an office and they tell me my cells are old. Well, part of the fact, I feel old. I'm injured. I don't feel well. I have arthritis. I feel old. I am old. So
Right.
Why would I use my old crummy cells when I can use some super fresh baby cells, right? So it sort of hits at the emotional core of the patient who's, not feeling as vital as they did at 21. I think there's that emotional component to it. And, the patient is a human. And I don't think it's unreasonable for someone who doesn't have the education or the data or the ability to look at the data in front of them or being given possibly false or slightly manipulated data. I don't think it's wrong for them to want easy, fast. You're in and out in 5. Let's put it this way, Ariana, if I could find a viable way to do something in 10 minutes in my office and provide the same quality, scientifically, proven quality that I'm giving them, the same amount of growth, why wouldn't I do it?
Yeah. No, absolutely. Yeah. If you are seeing 10 patients a day and you can do it in 10 minutes, you instead of 10 hours, okay. Yeah, like sign me up. But then what I'm going to do with my other 8.5 hours, maybe I'll take a nap or something. It is human nature, and we are always hoping for that magic bullet, hoping that it's going to be less hard somehow. Same with, like, if you look at the weight loss industry, right? Like, everybody's looking for that magic bullet, and it's like, well, diet and exercise is also helpful. And the GLP-1s are one part of it. Do they work? Yes, they do. Do they have, some issues? Yes, they do. If you don't change anything else about your diet and you still eat ho-hos and Doritos, if you stop taking the GLP, do you gain all the weight back? Absolutely. Right? It's not a magic bullet. And so we use these injection-based therapies in a similar way. This is not like a magic bullet. I can't turn back the clock to when you were 21. No one has shown that any of these injections, whether it be PRP, BMC, MFAT, Wharton's jelly, culture expanded cells, can turn the clock all the way back. We just are not there yet, right? This whole, issue about cellular senescence, there's so much to unpack that I always tease, we're now getting to the beginning of the beginning.
Exactly correct. I think I agree with you. And if you look at offshore clinics where they used to use autologous cells and culture expand, they now use birth products like placenta and they culture expand. And I was down in Brazil, I don't know, like 15 years ago, maybe. And they had a clinic there where they would use birth product cells. And they had this amazing, like, little freezer that would bring them they had a way to thaw them without lysing the cells. And that the freeze thaw process is where most of the living cells are killed. So, but this little device they had was like, $585,000 or something. So some crazy amount. So, I mean, the technology is out there. It's just, we don't have it in our clinics.
Right. And, in the US, there is a number of companies that are in that FDA trial for culture expanded. There's a number of companies that are pushing for acellular products, both, autologous and allogeneic. And they're going through those channels to
Correct.
be able to do that. We've had a significant number of hurdles. A lot of the companies are still in development. There's now a right to try act where if they pass the FDA safety data portion of their trial, now the US public has a right to try it for life and limb threatening disease. So it is coming along, but I think, we're not there. And now there's so many questions around who to trust and who to believe. I was just telling you this flyer, like the words on the flyer are pure nonsense. I'm like, this is not even like real. These things don't exist. These are made up terms purely for marketing. And so for that, from an ethical perspective, it's like, shoot, man. And like, if you are not even using normal scientific
Verbiage.
Yeah. Like, I can't buy your product. Like, what else have you fudged? What else have you not done your homework with? And really, the people always ask me why it is that they're allowed to market. Well, they're not, right? But the question that I have for everybody, and we all do this: how many people speed in their car?
That's a great question.
Like, everybody, right? Everybody. Is it legal?
No,
it is not legal, right? We are breaking the law when we go over the speed limit, right? But what is the ramifications? Are you going to get caught? Even if you got caught, is it going to be detrimental enough to curb that behavior? Same thing in this space. What is the downside, right? Minimal. I was just reading some of these award letters where they were like, oh, we're so sorry, FDA, we did bad. And they were ordered to pay. It was like 0.1% of their revenue.
Yeah, it's really, yeah, it is silly. It's not a big stick, right?
Right.
And even then, if you look at the plethora of people who are, even if you're not in a gray state, right? If you're in, I don't know, California, for example.
Yeah, let's say California.
Yeah, California. You know, you're not in a gray state, but people are still doing it. And a lot of it is sort of like, well, Joe down the street's doing it, he hasn't gotten caught kind of thing. And the truth is, you know, theoretically, if you get a letter, you keep doing it and you snub your nose in the FDA's face, you're going to have a problem, right? But if you are doing it and then you comply thereafter, you have to change your business model. But in the end, we should be doing what we think is right for the patient. And it's hard if you're getting mixed messages in regards to what's the most valuable way to approach something. And I have a feeling it's going to get a little more murky before it gets clear. So I'm interested to see what comes down the line.
Yeah, you know, we always talk, and there were some conversations in the chat about the fact that there's some bad actors in every field, right? And there are some clinicians that are knowingly like overselling because it's profitable. Like, oh, these baby cells are going to do great. As they're injecting them blindly with no ultrasound, they have no idea where they're going. And, you know, the clinic you explained is the clinic that was doing all of those things. They had a nurse practitioner that was overseen by a retired cardiothoracic surgeon to do joint injections. Blind, no ultrasound. With, you know, a vial. They didn't draw any blood. They did call it PRP, but they didn't draw any blood. So I was very confused about that. And PRP and stem cells is what they advertised. And so it's such and good news, their clinic is shut down when I drive past it. So that's good news for me. I think they've actually shut down, rebranded, and popped up somewhere else because I keep hearing about this. But, you know, do we want to believe the bus that, you know, the poor salesmen are just told what to say and they don't actually know what they're talking about? And so everybody's kind of like misinformed in the supply chain and there's just a few bad actors at the top? Or do you think it's more concerning than that?
I don't know. I like to believe the former. I mean, that's what I like to think. And I know some people who started using these. In fact, I know a guy whose daughter was a rep for one of these companies, and he was trying to get me to start to use them, right? And he was an orthopedic spine guy. And, you know, I never got a Christmas card after that because I didn't start to use them. But, you know, I think that we want to think the best. And I think that if you're given a white paper, right, and you read this about the cells and you think, oh, and then you have a colleague who's doing it, you'll probably feel comfortable doing it and start doing it without a deep dive. And really, we started doing it. And then once we realized we weren't getting the results after 6 months or so, you know, then we did a deep dive, right? But this was before there was multiple studies out there that showed no living cells after thaw on this group of products. So I don't know, Ariana. It's a good question.
Yeah. So ultimately, you know, what is that next step, right? How do you be successful? How do you juggle all these things? Like, oh, I don't know, what should I do? How should I do it? Should I do perinatal? Should I do birth products? Should I just stick with PRP? Because, you know, is MFAT kind of, you know, risky? Is it not risky? What about BMC? Is relying on elderly people's cellular and platelet health maybe hard pill to swallow for some of us who don't have that, you know, warm fuzzy feeling that, oh yes, everybody's cells work great. Shoot, you know, we know diabetics' cellular health is terrible. And we maybe should be considering biologic and metabolic optimization before we even step foot in that consideration of injecting. I don't care what you inject, if the host is not well. I really think that is another consideration, right? And
Sure.
So as we open and are pushing towards a thriving orthobiologic practice, or considering opening this micro practice, a service line within your current practice, we have our orthobiologic practice launch system. You know, that orthobiologic and injectable knowledge base that we just went over. We talk about how we attract the right patients, how to create a cash-based business, because guess what? We didn't learn it in school. How to have high-converting consultations or goal-directed consultations, and how to be successful. Money is inherently not bad. It just is, right? So if you want to know if you want the fast track, I would just offer you a little QR code. It's a tiny little quiz to say what your next best step is. If you want the deep dive, we are now holding a 3-day predictable cash pay practice workshop. It is only limited to 40 physicians, Scottsdale, Arizona, and we do so much with MSK ultrasound, AI practice tool implementation to save you time, effort, money, cash pay revenue infrastructure, and it's a private, personalized implementation environment. So this is a workshop style environment. We did just extend our early bird price till April 1st. Dates, June 5th through the 7th, so please write this down. If you want to check out the full guide of what we're doing, it's going to be truemd.institute/Arizona. So I'm going to just wrap this up. Thank you so much, Kristin. We're going to turn it over to the Q&A. There's not too much craziness. There's a little going back and forth, a little passion, if you will. So there is some questions. Is PRP BMac FDA approved, right? And I think we talked about this. If you'd like to share your thoughts, I get these questions all the time.
Yes, they are both FDA approved. They both have 510Ks for orthopedic applications. The caveat, like I said earlier, and you can disagree, Ariana, if you think I'm wrong, I mean, this is a discussion, is that it's approved for intraoperative orthopedic use. So the question is, if you're doing it in your office, that's really not intraoperative, so it thereby becomes off-label. But you could check with the manufacturer that you're dealing with. The majority of the manufacturers out there have 510Ks, but it certainly doesn't hurt for you to do your homework and make sure that manufacturer has a 510K for the device, right, with the FDA.
Yeah. So this was a great question. My understanding of off-label means that there has to be an approved FDA indication to have an on-label use. And you are exactly right. So the on-label use for PRP is for the improved handling of bone graft within surgery. That is the on-label application for PRP. So if you are not using it that way, which like 100% of us are not using it that way, then you're using it off label. But that is correct. My favorite way to think about this is heroin is a drug. It does not have FDA approval. Therefore, you cannot use it off label because there's no on-label indication for heroin, although it does exist and is for sale and for enterprising young or old people. So I think it's a good benchmark because there's now, there's peptides and just because it exists in the market doesn't mean that there has been an FDA indication or has gone through FDA trials or any of these things. It just exists in the black market or the gray market, if you will. So yeah, absolutely. Let's see here. There's a question. There are practitioners actively marketing Wharton's jelly stem cell treatments administered via IV and nebulizers. Ooh. Your thoughts, Kristin?
No, anything FDA or anything FDA, anything IV or nebulized is so off. It's non-homologous. It is so not FDA okay. And, there have been multiple clinics that have been shut down for that. And really, where's your indication of its efficacy for that application and risk, right? Yeah. And there are a lot of clinics offshore doing this, and some of them have great results, but it's a whole different, to me, what they're doing in Panama or wherever. It's a different thing than what we can do here.
Yeah, it absolutely is. I was talking to one of the founders of VetStem. So
Mm-hmm.
VetStem has been in business. It's a veterinary culture expanded cell company. It's been in the veterinary world for 25 years plus. They now have a human branch called personalized stem cell. And so I was talking to Bob Harmon, who has been doing, the vet stem forever and ever, and their protocol is intra-articular injection of the culture expanded, adipose-derived culture expanded MSCs, as well as IV. But when I asked him, when you're placing things IV, what about that first pass? What about the load through the lungs? And what is your thoughts on that issue? And he was like, oh, well, I haven't really thought about that. I was like, oh man, okay. I'm not sure. I've been presented opportunities for IV stem cell infusions, and I think we don't have all the information about what happens to those cells, where do they go? Maybe if you're treating for lung-based issues, maybe it's brilliant, right?
Yeah, the idea of think about COVID and
Right.
these, what PRP can do to a cytokine storm and, or even stem cells. I mean, gosh, what a brilliant idea, right? But it's just not, it's to me so far off the reservoir or reservoir. No,
Reservation, yeah.
reservation. Sorry. I live by a
Or
reservoir. I
reservoir.
got reservoir on my mind. And it's so far off the reservation that I just am like, eh. But then again, patients are desperate, right? You have COPD, you have Parkinson's disease, you have ALS, and you don't have 50,000, 25 to $50,000 to go offshore.
Yeah.
And
Yeah, I know.
that spot.
Yeah, and the FDA is not without the other part of this, which is it takes millions and millions and millions of dollars and 10 to 12 years of product development to even get pushed through.
Right.
And I'm sure, as always, if you're wondering about why things are weird, check the money, right? So I'm sure there's plenty of that issue as well. So yeah, I don't think this is a solved problem, but I do think that the physicians, the onus is on the physician to be educated about what the FDA stand is, what the state rules of the manufacturer, as well as the practitioner rules, as far as it comes around, viability, post-thaw viability testing, which, I think in one of these conversations was like, okay, there's X 100 million, but don't they come frozen to your clinic? So how are they able to show post-thaw viability? I don't know that answer, and maybe I need to delve into.
That has to be, I think, done. I think they have to, it's a good question. Do they take a batch?
Yeah.
And do a post-thaw viability on a batch at the manufacturers and then send the rest of the batch off? Because remember, you get a lot of product from one placenta.
Right.
So I don't know exactly how they do that, but obviously they're not in your office doing CFUs, right? So they're not culturing them right there in the office. So I'm not sure how they do that. And I can't believe with the plethora of clinics that are out there actually using this product that the manufacturers are actually providing. That's the question.
I mean, if anyone's on this call and has insight on, do you get, post-thaw viability? They, on the conversation on the chat, it says, yes, they must provide to the patient a lot, and each lot must be, assuming that they are frozen and thawed by batch. So no kidding. You're absolutely true. I think that what they are supposed to do and what reality may be happening is maybe two different flavors.
Yeah, because you think that if there was that much data that they had, I mean, there's a lot of product. These manufacturers have money. I don't understand why they haven't done a study. You know what I mean? If I am this company and I have this much, I mean, there is the one that's right now trying to get an IND with the FDA. They're obviously going to have to do studies that show the viability. So I don't know. It'll be interesting.
Yeah. Well, I'm going to Colombia to Medellin next week, so maybe I'll report back after my seeing how the secret sauce is made.
Yeah, it's pretty interesting there. Like I said yesterday, I was supposed to go last year and had to cancel, but I think that it's a great clinic. I think they do good things. It's going to be interesting to see that whole other side, right?
Yeah, that does not exist in the U.S. currently.
Exactly.
So. Well, again, everybody, thank you so much for joining. If you're interested, go ahead and just log on to the TrueMD Institute.institute/Arizona. And if you didn't take the quiz on how ready you are to add orthobiologics to your clinic, please take the quiz, and then we'll see you in 2 weeks for Conversations in Regen. I have a treat for you all. It's going to be a St. Patty's Day treat with Dr. John Kanab. So everybody stay tuned. Come back next in 2 weeks, and we will see you there. Thanks so much, everybody.